This week on the BackTable podcast.
But what I think that the data does is that it gives comfort to patients that, okay, other people made it through. And I usually say patients are resilient, right? I don't think there's a right or a wrong option. We just have to find the best option for you. And then this is also a really good part where you bring in, okay, so what are sort of your goals? What are things you're looking forward to in the next few years? What are things that are important to you? What do you want to do? Because that's where you really sometimes get some of that understanding on, is someone really informed? So if they're like, oh, I'm really worried I'm never going to be able to swim again. Well, that's not true. You can indeed swim with a urinary diversion, right? And my former patients who have chosen both paths and are willing to talk to current patients about how they kind of went through that process. And then there's also our big patient advocacy organizations. Beacon also has a peer support and outreach program that can be really helpful. So I do think it's like an iterative, pretty complex conversation. I do think that data I bring that in right when patients ask that question. And it sort of helps you sort of sort through, is this going to be the right thing for the patient? But it also lets you know what they're worrying about, because it's not always what you expect.
Welcome to BackTable. I'm Vig Packiam. I'll be the host for this episode, and I'm super excited to have two superstars and friends with me today, Dr. Sima Porten from UCSF and Dr. Pat Hensley from University of Kentucky. Do you guys want to give a brief introduction of yourself?
Sure. My name is Sima Porten. I'm a urologic oncologist at UCSF. I also am the director of our fellowship program and the chief of our division.
I'm Pat Hensley. I'm a urologic oncologist at the University of Kentucky in Lexington. I am a urologic oncologist. I also do a lot of benign abdominal reconstruction, co-lead for our clinical trials program, and most of my practice is focused on bladder cancer.
So today we'll be talking about patient-centered diagnostic and therapeutic approaches for non-muscle invasive bladder cancer. I think it's a ripe time to be talking about this. We have so many exciting therapies, new biomarkers that are coming out, potential for precision medicine. But how does this all connect to the patient? How do we talk to patients about this? Really important to talk about. So let's kick it off with communication. We can start from the very beginning. Sima, let's say a patient comes to you with hematuria and we're just starting the diagnostics with CT urogram, cystoscopy. Can you walk us through how you discuss these things with the patient and what that discussion's like?
Sure. So I think for any of these discussions, it helps to have a framework to set the stage. And so the great news is that our national bodies have some pretty good guidelines that help you frame things to talk to patients so they understand why you're doing something and what you're sort of worried about, right? So I usually address the elephant in the room because they're actually coming to the cancer center to see me. And we talk a little bit about when patients have either microscopic or visible hematuria, what that implies and why they're talking to a urologic oncologist without a diagnosis, essentially. And then we talk a little bit about risk. We then from that, it's a different risk if it's microscopic hematuria versus visible, right? And I do also acknowledge that often we don't find a cause. In many of these situations, we talk a bit about the CT scan and what we really are looking for. You're looking for benign conditions like stones, why you need the urogram phase, because many have come with a standard CT or some with like an X-ray, and they want to know, well, why do I have to have this other test? So you kind of explain the rationale for that. Then probably the most time is spent on what a cystoscopy is and why you need it and how we perform it. A lot of patients ask, is it going to be tolerable, really painful or not? And you sort of go through those expectations. I think when people know what to expect and why you're doing things, it makes hopefully the process a little easier for them.
Yeah, I think that's really great. That's a really good point about mentioning that we might find benign pathology or nothing, because that can be frustrating for patients. But I tell patients that's a good problem to have if we're not finding anything too serious. So Pat, let's say that the CT urogram shows, nothing too remarkable. You're doing a cysto in the office and you see a tumor. How do you address that? Do you immediately tell the patient you're seeing something abnormal? Do you wait till you're all done to have that discussion?
Yeah, I think you got to read the room and kind of personalize that approach a little bit. Hopefully you've built some rapport with the patient. It might be your first time meeting him. Somebody might have referred to you just for the cystoscopy, but at least you've consented that patient and you've had the ability to kind of introduce yourself. I think it's important to describe exactly what you're seeing to the patient. Oftentimes, if the patient's not already watching the screen in the monitor, we do all these awake in our clinic. If they're not already watching, I offer them the opportunity to do so. And I'll describe, the lesion and kind of the architecture and what has me concerned. And if I'm, pretty certain that this is a bladder cancer, I try to use that actual terminology. I think some patients get a little taken back or kind of misled when you use things like mass or tumor or lesion, because their TURBT report comes back and you call them on the phone and say, well, you've got, high-grade bladder cancer. And they're like, wait a second, I have cancer. And it's like, yeah, we talked about this. You saw the tumor in the office. And it's sometimes patients need to actually hear that word. And papillary lesions, we can usually tell with a high degree of certainty that this is a concerning lesion. I try to describe exactly what the patient's seeing. I think it also helps, when these patients undergo surveillance scopes, many times they kind of buy in and they want to watch the screen, and they're pointing out different lesions as we're going and mapping the bladder. And we'll talk about each one and kind of, discuss what's concerning and not concerning about various lesions in the bladder. And that gets patients to kind of buy in. When they see a tumor, they understand the importance of the TUR and adjuvant intravesical therapy and those kind of things. So I kind of address it head on, but you got to individualize it a little bit for each patient.
Yeah, I've always kind of handled it the same way, describe kind of the features of it, and then, maybe go through some of the other aspects of what it is afterwards. We were at the Bladder Cancer Advocacy Network recently, and we had a patient advocate panel. And interestingly, there were some patients that actually said they'd prefer not to get that information during the cystoscopy. So we probably do have to tailor it based on the patient. Yeah,
and I think you also recognize when there's an equivocal lesion and we don't know, say a patient's heavily pretreated or they've got a patchy erythema and a history of CIS, you just admit that we're not certain based on the cystoscopic appearance, and we might need a biopsy or cytology to adjudicate those findings, and you just admit that. And again, patients are pretty understanding of that.
So next step, this patient's probably going to get a TURBT as the next thing. Are you counseling these patients on what the possibilities are from the TURBT from a path standpoint ahead of time, or do you table that for after the procedure?
Again, here's where you hope you have some relationship with the patient and their family, and you can kind of ascertain what their preferences are, but I usually just ask directly. So I will usually say we do need to do another procedure in the operating room to better characterize this. The majority of these are indeed cancers. There are some that are essentially benign or non-aggressive, and then there's a spectrum as you kind of move through clinical staging, right? And usually what I'll ask a patient is I'll let them know that there are many, many paths that you may need to walk down. I can certainly go over all those now, or if you prefer to take it a step at a time, we can do that too. And then they tell me which way they'd like to go, right? And some do want some framework of all the things, even to the diagnosis of possibility of like metastatic disease, right? Which hopefully you've had imaging in that beforehand, and that's not the case. But some like having all of that up front because it helps them cope. And others just want to do one additional step at a time and get the information in that way. If someone says, I would like it one step at a time, I'll then come back to them and say, I need you to know 3 important things about this TURBT. 1, like what we expect from it. And then, you talk about recovery, catheters, those kinds of things. 2, I talk about the possibility of gemcitabine, why or why not, at the time of surgery. And 3, I always bring up the possibility of needing to go back for a re-resection. I think that's important to let patients know based on findings that might be in their future as well. So that's sort of how I do that counseling and conversation.
Yeah, that's an awesome way to do it. Just ask the patient what they prefer and kind of let that guide the discussion. So now you're doing the TURBT, let's say you see multifocal disease and maybe there's some concern for invasion. Can you walk us through, you leave the operating room, you're talking to the patient's family. How much are you telling them? Does it depend on, their family relationship? Do you tell them less or more, or wait for the path?
Generally speaking, after TURBT, that's always a family I'm going to go physically sit with and talk to, because there's a lot you can glean from the resection. Obviously, you're waiting on definitive pathology, but if it's a high grade appearing tumor, potentially invasive spectrum tumor, I'll actually sit down on a whiteboard and kind of draw out bladder cancer staging. And that way, because I generally call patients with pathology on the phone just to have that initial discussion and then bring them back into the multidisciplinary setting in person. But when you call the patient and their family and they put them on speakerphone and we're having a discussion about the pathology results, they've already got the stage and grade framework kind of in their minds, and they can kind of anticipate next steps based on the final pathology report. I'll mention things like the potential need for a restaging resection. I think that's important because that'll take some patients off guard because they're still kind of reeling from the index resection, and all of a sudden you're taking them back to the operating room. So we'll talk about, the various differences between non-muscle invasive and muscle invasive bladder cancer. Try not to go into too much detail, but kind of some nuances in staging and grading, kind of what next steps are based on the report, so that when we call them, they're kind of prepared for that.
Good points. And this probably pertains to all the aspects of counseling, but have you found that patients are getting more educated via artificial intelligence, ChatGPT, different online resources now?
I think it depends on the patient. I do give them resources such as Beacon, right? I think that website has pretty great information, and I talk to them how to navigate it based on pathology findings and those things. I think they have a great initial handbook called Bladder Cancer Basics, right? And so I think that is a great resource. So I think some definitely Google or ChatGPT, but as physicians, if we can point people toward resources, if they would like to have more information and read more, I think that's a valuable thing. So I do tend to do that. Yeah. But I think it really, really depends on patients. I think you can give patients a lot of things to read. And then I have a lot of people who just are like, I didn't do that. I'm just going to wait until I talk to you. And I have others who have read everything. I have others who have pulled articles and read it. I'm like, it's actually, you understood that article pretty well, right? So you get this wide range of patients, just like in life. There's wide range of people, and you just have to meet them where they're at.
Yeah, obviously there's the potential for misinformation, misinterpretation, but for the most part, I love when patients try to educate themselves and look up resources. It makes the discussion a lot better. So, all right, good. That was a good coverage of how we communicate. Flipping gears a little bit to managing symptoms. I think this is something that is very important now with all of our different treatments. Patients are keeping their bladders longer, but it sometimes gets swept under the rug during our training of how to really do the nitty-gritty of having patients tolerate the treatments the best. So again, starting from the beginning, just with the office cystoscopy, what are you counseling patients on what to expect with symptoms, and are you recommending that they do anything to try to help their recovery after the procedure?
Yeah, I think Sima and I were talking about this on the way here. It starts with the patient's holistic care, and from the moment they walk into the office, just kind of setting the ambiance, and the staff that's preparing the patient for the cystoscopy, takes a big part in kind of setting the tone and kind of relaxing the patient. I tell my residents that you got to use a lot of verbal anesthesia. So patients like an open dialogue. They don't want any surprises. They're awake. They can hear what we're saying. So these are sensitive exams and genitals. And I think from the moment that you take down the drape and start inserting the scope, just tell them everything that you're doing. Tell them where the scope is. In a male, we're going through the urethra now. Relax here. We're going through the sphincter and the prostate. And I think that helps a lot. When I'm teaching and I'm showing residents or students different parts of the bladder and the ureter orifices and those kind of things, I'm talking to the patient as well. And again, they get kind of, some buy-in to the procedure. There's some data that suggests that patients who look at the monitor during the procedure have a little less anxiety and pain compared to folks that kind of distract themselves and ignore the monitor. So I do use those approaches. After the procedure, I just tell the patient, stay well hydrated, some hematuria is to be expected. I do counsel them that they're kind of predisposed to urinary tract infections and to have a low threshold of calling us and kind of keeping us updated with any changes.
Verbal anesthesia, I love that. I'm going to use that. Sima, do you have any other tips of what you do during the procedure?
Yeah, I think really it is, I'm very, very privileged and blessed to work with some amazing LVNs who sort of make the experience as calming as possible, right? We do use intraurethral lidocaine for both men and women. And I think that helps to some degree, at least it mentally helps patients for sure. I do think the chit chat is great in explaining exactly what you're doing. I also think, it's a good time if you're training somebody or teaching someone, it's also a great time to talk to them about cystoscopy techniques, right? So you wait till the external sphincter relaxes. If you have someone breathe deeply, and when they breathe out, you'll see an opening. And that's when you should advance the scope, right? That's probably one way to kind of mitigate pain. External sphincter has to release at some point in time because it's a voluntary muscle. So you can take advantage of that. When you're actually physically doing the cystoscopy, the most painful part is manipulation at the bladder neck, right? So if you're also doing procedures too, like biopsies and those, just have to minimize the movement that you create at the bladder neck. And particularly retroflexion is fantastic at helping you see around big prostates with the least amount of pain, right? So it's that flexion up and down there that always hurts the most. And so I think if you explain it, you can say you're going to feel a lot of pressure. You actually may feel like you need to urinate. Don't worry, just relax and let it go. It's fine. We're already making a mess with the irrigation and all of that. And so I think explaining that to patients helps too. But those are a couple of the tips that I, share with our residents, and that because often we expect them to know these things when they've only done them in the OR, right? And so I think these are important pearls to sort of pass on.
I'll add that our clinic has adopted inhaled nitrous, which is great because it's quick on, quick off. Patients can still drive themselves. We use it for a lot of transperineal procedures. Some patients caught wind of that and wanted it for their cystoscopies. And to be honest, when they come back for their next surveillance, they actually forego it. They don't think that it helps that much. So the verbal anesthesia and just kind of, being with the patient, being present with the patient is usually enough. So I haven't found nitrous to be particularly helpful for cystoscopy.
Yeah, I think nitrous, some practices are using it to do a lot of in-office procedures, but it's a little cumbersome to get onboarded into the clinic. But if you have it available, that's a great technique. Love the pearls about the external sphincter. I think that's so useful in real practice. And retroflexion, I learned that over time. I mean, in the beginning, you're trying to do as much as you can before you retroflex, but now I have a lower threshold to just retroflex and see that bladder neck. What do you guys think about music? Do you use that during the procedure, or have you considered that?
I don't use it routinely. I do have one LVN who, that's his like thing, how he sets up patients. So I let people, like primarily our nurses who are the ones helping us and been actually doing a lot of the work, right, in reducing anxiety. I let them, do their thing. They each have their own vibe and it works for them. And I think it really helps the patient experience. But I haven't routinely introduced music or anything in there. I have some patients who like playing certain things. I have patients who like putting their loved ones on video, so get to see everybody, like the family, and then they hold the camera to the screen, like those kinds of things. So I sort of let people do what they're comfortable with.
Yeah, when I was in training, we actually did a randomized study during prostate biopsy of music versus no music, and we found no difference. Part of that is because we had some great verbal anesthesia from the doctor that did it. He was really good at talking to the patient. So I think that's the number one thing to do. And then what about Urology? Are you guys using that routinely? Do you think that makes a difference? Does it have to sit there for, X amount of minutes?
We use it. I'm not sure how well it works. I think there's a placebo effect for patients. Sometimes we'll get a little behind in clinic and the Uroject's been kind of dwelling for quite a while. Sometimes we'll put it in and start immediately with a scope. And just anecdotally, I don't think the dwell time matters that much, but we use it in all of our patients and the patients ask for it. If you're about to scope them and they haven't had their lidocaine jelly, they ask for it by name before you get started. So.
And are you using it in men and women, or mainly for men, or?
Use it for both. And our LVNs definitely have, they're like, this is the right way you do it. So you put a little at the meatus and then they chat and talk to patients, men or women, and then they put like the whole sort of tube in. I think the lubrication honestly is the most impactful part of it. So I actually think it is useful from that aspect. From the lidocaine part, I'm not sure. A couple residents this was a while ago, did an experiment where we put a bunch of tubes just on our arm to see if it would numb areas. That's not the really right place to sort of do that. But we were just kind of curious, topically things like Emla cream and that work, right? So you would anticipate Urology may too in a mucosal area, but I think that it's really nice because I do think the lubrication part of it is probably its greatest benefit.
Yeah, the main thing I focus on is making sure the entire cystoscope is totally lubed up, because that's the last thing you want as you're doing that.
Exactly.
That's really great tips for office cystoscopy. So moving on to the TURBT, when you're talking to your patients about what to expect after the procedure or how their recovery is going to go, can you tell us how that conversation goes?
Yeah, I really contextualize that based on the patient's prior experience. So if they're a first-time TURBT patient that we're taking to the operating room for a procedure under general anesthesia for their index resection, that counseling is a little different. I talk to them about the need for adequate tissue sampling. Again, if it's kind of a high-grade or invasive spectrum tumor, we talk about the need to get a deep biopsy, including muscularis propria. I try to destigmatize the whole concept of a bladder perforation, because sometimes, for an aggressive resection, you're actually intentionally getting through transmurally through the bladder wall, but you also have to talk to them about the risk of a intraperitoneal perforation that might need repaired. So you got to have that conversation with them up front. I spent a lot of time, like you mentioned before, talking to them about the potential need for a catheter postoperatively, both for bladder rest and also for perioperative chemotherapy. We talk about the expected, postoperative irritative lower urinary tract symptoms and hematuria. If the patient's been through resections in the past, I start by seeing what their experience with those resections are. A lot of patients come to us having had repeated resections at the outside facilities. Sometimes they're routinely admitted to the hospital at those outside facilities. That patient might have come back in clot retention and had a terrible experience with catheters and ERs. So I think you just got to meet the patient where they're at, kind of get a holistic view of what their experiences have been in the past and start there with my counseling. So, but I think it's really important to especially set the stage that the patient may wake up with a catheter for variable duration, depending on how the case goes, and certainly talk to them about perioperative chemotherapy. This may be the patient's first exposure to intravesical therapy. And a lot of them don't know that it's not intravenous or systemic therapy, and it's not going to make their hair fall out, and it's not going to make them, sick. So we talk about, typically I kind of, focus on the fact that they'll be emerging from anesthesia and kind of sleepy while the chemo's in there, and then we'll drain it out. And I just kind of walk through that whole pathway.
I personally don't really go into the bladder perforation thing or needing for XLAP unless maybe it's a high-risk tumor on the dome. Is that something you're routinely talking to all your patients about?
Not necessarily. I think my residents do when they consent every single patient, even if it's a little low-grade TA lesion at the trigone, but it can spook patients a little bit. But yeah, a high-risk patient, elderly woman with an invasive lesion at the dome, absolutely. You gotta talk to them about that.
And post-op recovery from TURBT, oftentimes we're prescribing different medications. Are you going into the details of that before the surgery, or do you leave it for afterwards?
Typically, and again, in the kind of consultation room, I'll talk to the family about the protocol that we use after surgery. But preoperatively, we talk to them. You're going to have irritative urinary symptoms. We'll prescribe antispasmodics and analgesics, and just kind of prepare them for the fact that we have tools to kind of ameliorate some of the expected side effects.
Yeah. I think it's a balance, because we don't want to overload the patient with all the possibilities and information, but we also want to be open about everything that could happen. So Sima, you're in the operating room, you're doing the TURBT, patients had been counseled about all these possibilities. Are you tailoring your resection with an eye towards how they were going to recover after the procedure?
Yeah, to some degree. I think this comes into play in primarily when you have a bladder that has a really high volume of carcinoma in situ. Right? There's morbidity to how much of that bladder you resect. And if you have information going in there that this is what's likely going on, and it's not really like nodular sort of tumor, then you can kind of forego needing to either cauterize or resect like the entire bladder, because in the end intravesical therapy is what your destined path is, right? So I think part of it is as a surgeon and thinking about the future, you got to also think about, well, what do you think your game plan is going to be with these variety of diagnoses that you may end up with? And I ask the residents this all the time. I'll say, what's your plan? And it's the plan in the OR, but I'm like, well, what's your plan after? And they're like, well, I don't know. And I'm like, we should kind of think about your plan after, because that might guide what you do right now in the operating room, right? Are you going to put gemcitabine in someone who has a pretty obvious high-grade, large volume tumor? They're like, but gemcitabine's part of the guidelines. I said, but okay, where does it work, right? So some of it is just thinking about those possibilities and trying to anticipate it so that you can do right by the patient. Obviously, if you see carcinoma in situ and you're like, oh, that looks like carcinoma in situ, but it's has a little more mound to it, you want to resect that one, not just biopsy the surface of it, because there could be invasive tumor kind of underneath. So you have to kind of think about, okay, I'm the detective. It's my job to figure out what is going on so that we can really make a logical, correct plan for the patient. So that includes how much or how little do I need to do at this one point in time to get the information I need, right?
Yeah.
So
I think you make a really great point about we don't need to do these monster bites and getting muscle and seeing the fat if you're seeing CIS, and we could probably tailor this so the patient recovers a little bit better. Another little finer point, for repeat TURBTs, let's say you're going in, someone has a history of high-grade T1, you're re-resecting, you see a scar. Are you formally re-resecting those every time, or do you do biopsies, or does it depend?
It depends to some degree. I do formally re-resect them, in particular if their bladder has seen a lot of intravesical therapy. Because when you think about some of the data coming out with really long duration of bladder preservation, because we have a lot of agents, and you look at the bladder and the scar and the remodeling, I get more worried about things under the mucosa, which is what I see actually quite a bit. It's fine. The surface urothelium is fine, but underneath it's not fine. So in those situations, I do tend to actually re-resect the scar or previous areas. When you're going to re-resect for a high-grade T1 and you need muscle sampling, you need muscle sampling. So if you're going to get that with your biopsy, fantastic. But if you need a loop, then that's probably necessary. You can look at other things like what's the state of someone's urethra and bladder neck. Particularly, many patients have had prostate cancer and radiation and those types of things. And you can say, okay, do I need to put a resectoscope in? So do I need to do urethral dilation, put a resectoscope in to get muscle? If you look in that bladder and you do, then you got to do it. But if you look in there, you're like, okay, this was a small tumor on a little stalk, but it was T1. I can get muscle in the one biopsy bite. So then you choose to do that and kind of go with the smaller scope, right? So I think you can use all those factors in deciding, again, how much do you need to do and how much do you not need to do to help with patient tolerability. But in the end, you kind of got to know why are you doing that procedure to begin with and what information do you need to make the next right decision, right? So that's kind of how I look at re-resections or multiple resections.
I kind of go through a checklist with the trainees in the operating room. I ask the same questions for each case. Could we cure this patient today? So is it papillary disease that with a good resection that you could potentially cure the patient? Do we need to sample muscle? Yes or no. If it's recurrent low grade and it's a small low grade appearing tumor, you don't necessarily need to sample muscle. And then just kind of another cautionary tale I see, sometimes with the trainees is when you're going back in, especially for restaging for a high grade T1, you want to sample muscle in the resection bed, not in the penumbra or the surrounding tissue. That doesn't help us, right? So you have to take the deep bite or the deep swipe with a resectoscope in the resection bed at the index resection.
Yeah, that muscle sampling question is tricky. I've always wondered, does it really matter if you get one little whiff of muscle from one place, or do you really need all of the muscle underneath the entire resection? I don't think we have a good answer to that question. I saw a really interesting study from Japan recently where they actually did repeat TURBTs, and if they were negative, they would just do watchful waiting, and the outcomes were pretty good. So doing a good resection, can't be understated.
That was seen in a few randomized controlled trials, right? Nimbus study, totally different, slightly off topic of what we're talking about, but looking at using less intravesical therapy, BCG. And the interesting thing in their study is that they did a re-resection until there was no residual disease. So sometimes patients had 3 TURs prior to intravesical therapy, and the recurrence rates across both groups, and even the usual standard BCG group, was some of the lowest that we've ever seen. So I do think there's some nuance to how big of a TUR do you need to do. Obviously, if you go too intense and it takes someone 3 months to recover, that's not really ideal if you're planning intravesical therapy. So there's probably a balance there.
let's talk about recovery after the TURBT. There's a lot of medications that we can give to help with recovery. What's your standard pathway? Do you have standard medications that you use or, to escalate in certain high-risk patients?
Yeah, we typically prescribe anticholinergics. We try to avoid anticholinergics in elderly patients due to the kind of dementia risk and constipation risk. So we'll use beta-3 agonists in those patients. Everybody goes home on Pyridium. We tell them to liberally hydrate, but that's kind of the basic package that patients, are counseled on and go home with postoperatively.
Are your patients typically getting pericath pull antibiotics for the Foley, or are there other medications that you use around that time?
Yeah, so we usually give education around. So first is like behavioral modifications while you're recovering, avoiding caffeine, citrus, spicy foods. We're borrowing a little from the bladder pain syndrome literature, right? So we talk about bladder irritants and trying to avoid those as you're trying to heal from surgery. I do talk about making sure you're hydrating enough. Also, that is for avoiding constipation, right? Because I do think that sometimes constipation definitely makes bladder symptoms worse, as well as hematuria after. I do warn patients that many will have another bleed. Usually when like the scab or tissue sort of falls off, it's somewhere around 10 days or so that it usually happens, 10 days to 2 weeks. So I do warn patients about that because I think it can be unsettling when all of a sudden you've been doing great for like a week and then there's like, it looks like a massacre in the bathroom, right? And so I do warn patients about that and then what to do in that situation. We use Pyridium to non-narcotic anti-inflammatories, Tylenol, ibuprofen if it's sort of safe. In terms of antibiotics, we do follow AUA's white paper recommendations. So a catheter in more than around 72 hours or more, we do give periprocedural antibiotics. If it's short, like you just need someone to have it for a day or two, we don't. And in those situations, I talk about beforehand if someone wants to learn to remove the catheter themselves. And then we have a nurse visit sort of scheduled around that same time we plan to do that so that someone can check in, because occasionally sometimes they want to, but they can't. And then we make the appointment in clinic. But that kind of helps patients coming from far away, or we can help set up appointments closer to home.
And how long is the antibiotic duration? I think the guidelines are not, super granular about that. Do you give one dose, 3 days, somewhere in between?
We usually give one dose in that setting. We'll alter based on prior experiences. So if someone had a real struggle with recurrent UTIs and those types of things, I may adjust and do day before, day of, day after, similar to like our stent pulls. But usually it's a single one, day of.
So Pat, you touched on this a little bit, but someone who's had many TURBTs before, are you able to predict who's going to have more issues after the procedure, and are you counseling those patients differently?
Yeah, going back to the original point, you gotta characterize the patient's prior experience with TUR. With bladder preservation comes lots of endoscopic procedures, biopsies, resections, lots of tiers and rounds of intravesical therapy. And all of these things are taking a toll on the integrity of the bladder, both storage and emptying function, right? I don't see that patients can objectively state that their bladder function is deteriorating with each additional resection or each additional intravesical therapy, but kind of taking a step back and holistically looking at a patient's bladder function and pain and symptomatology, it does kind of deteriorate over time, and you have to counsel patients on that. Most patients are highly interested in bladder preservation, and that comes at a cost of these repeated procedures and treatments that can weigh on bladder function.
Yeah, I've anecdotally found that if you do a big TURBT on a patient who's had many procedures before, sometimes it really is a much bigger recovery, and it takes months for them to get back to their baseline.
Yeah, and back to your point about kind of trying to resect all CIS or doing kind of a heroic TUR in a potentially unresectable tumor, that you're going to push that patient towards a cystectomy pathway, whether they like it or not, because they're going to end up with a highly fibrosed bladder without any capacity, and so there's a fine balance there.
I think this is going to be our next sort of research or study focus, right? Because now that there is a possibility to do bladder preservation, I think the question is how can we improve patients' experience through it, right? I think in cystectomy, that conversation started probably like 10, 15 years ago when I was in fellowship with enhanced recovery after surgery. That was like the big thing happening, and working on patient education prior to it. And I think we're probably going to see a change in research, and you're already seeing it in the type of publications. And I know you have a lot of interest and work in this for TURBT and these intravesical therapies and procedures. How do we improve quality of life on that? And I think it does, we see that a little bit in the CISTO study, right? And the results of that were surprising, that patients who underwent radical cystectomy actually had a pretty great overall, in the end, quality of life from that perspective. But to me, when I looked at that, I was like, okay, kind of makes sense, but it means that for us, for our community, we probably have to do better at paying attention to and managing and hopefully maybe mitigating some of these side effects. I don't know how to do that right now, but I think that is going to be a really interesting research focus kind of in the future. Particularly that kind of goes with what's happening in medicine in general and some of these regenerative sort of therapies, techniques, etc.
Yeah. No, so that's a really good segue to kind of the next discussion topic, which is once you have the diagnosis, we want to do good shared decision making with the patient. We want to outline all the possibilities from all of our treatments. And let's say someone has newly diagnosed cancer. Traditionally, we're using BCG, but with the BCG shortage and new therapies out there, it's a more complex discussion than what we used to have before. So can you walk us through kind of how that initial discussion goes for someone who's newly diagnosed?
Yeah, take treatment-naive, high-risk non-muscle invasive bladder cancer as kind of the index patient. I talked to them about the fact that intravesical BCG is kind of the de facto standard of care. In the era of BCG shortage, which is still tremendously impacting my practice, I don't know about you guys, but it's a big problem. I do talk to every single, high-risk patient about sequential gemcitabine. And we talk about the limitations in the data. We talk about, that it's technically kind of off-label, never been prospectively validated, et cetera. But well-annotated, well-performed retrospective studies suggest that it's efficacious, it's well-tolerated, it's cheap, it's available. And I think, oftentimes if we have enough BCG in stock, then I'll, throw it in the patient's lap and help them make a decision, kind of how they would want to approach their first line in the treatment naive setting. An obvious third choice, and we work in academic centers, is a clinical trial. And clinical trials are a little harder sell to patients in the treatment naive setting than they are in kind of a BCG unresponsive treatment refractory setting. But what I tell patients who are considering a clinical trial is basically the point of those is to either, increase the efficacy and increase our CR, or, potentially choose a treatment that has a more favorable dosing schedule, like it's Dildren with quarterly dosing, et cetera. So, or both. Maybe the experimental therapy is both more efficacious and more tolerable. So those are kind of the three in the treatment naive high-risk setting. It's BCG, gemcitabine, or clinical trial, and we kind of walk through each of those and help the patient make a decision.
Yeah, I think a lot of us in academic centers, we tend to be lucky that we don't have an absolute BCG shortage, but oftentimes we get just a little bit. So you could give a patient BCG, but you're looking at alternatives. Gemcitabine is something that's available that most people are able to give, and clinical trials. So those are all good things to balance. We can think about the efficacy of all of these options. If you're in that kind of a scenario where you have those three choices, are you counseling patients based on how you think they're going to tolerate the treatments also between different options?
Between the different options, yeah. So I think, again, having that framework on this is a risk, this is if you do nothing, what do I expect? So say that you go on surveillance, right? What would I expect to happen? It's not what I recommend, but I still talk about it. And then you talk about the different options. You can add in biomarkers if you've got appetite for it. And I know there's going to be some discussion and podcast about that. So I do add that in. Often some patients understand that discussion around limitations right now of our current biomarkers. And some are very interested in that, in using to personalize it with the caveats it comes with at this time until we have our data from some of our recent RCTs, right? And then the other part is just practical life aspects of it, right? So can a patient come to UCSF? We have BCG. We've been able to weather the shortage, but we've done it through full dose induction, half dose maintenance. I haven't had to reduce maintenance schedules, but everybody who gets maintenance gets half dose. And with that, we have BCG to kind of accommodate for all our patients. So I do disclose that part right? And then I disclose our experience with it in terms of oncologic efficacy, which doesn't seem to be impaired, but tolerance seems to be much better. In these last 5 years, we've been doing that. So we'll discuss that a little bit, and then we'll discuss, is that a possibility? Because some patients can't drive for 8 hours once a week for 6 weeks, and then for the CISTO, and then for the maintenance. That is very impactful in terms of finances, life, just how that works in the family structure and other responsibilities, right? And so sometimes gemcitabine is available closer to home in those situations. Sometimes it's not, and BCG might be available closer to home. So I find that half of the conversation is kind of sometimes focused on some of these personal and just really practical, almost social factors, right? And we're trying to navigate structure and schedule and logistics, right? Once you pick the treatment, now how may that change or be altered by what is actually accomplished in real life? And I think that about half of some of my conversations are primarily focused on that, like how is somebody going to be able to do all these treatments? And sometimes clinical trials, depending on what you have open in that situation, may actually be easier. And that's why it's nice to have that access to that portfolio.
I'll add that, when you're having the discussion about starting induction adjuvant intravesical therapy, you have to go ahead and brace the patient for the surveillance cystoscopy regimen that they're going to have and maintenance, because we know that for high-risk disease, maintenance is vitally important in kind of maintaining that response. So, sometimes patients are caught a little off guard. They went through this rigorous induction, their scope is negative, and then you say, okay, now we're going to start maintenance therapy. And if that hasn't been broached with them, and that can be a little distressing.
Let's say you have a patient that really wants to get in the nitty-gritty of side effects. It used to be if we only had BCG as an option, we talk about side effects a certain way and a little bit of it just can't be helped. Now that we have more potential options, are you diving more into the details of all what they can expect from the intravesical therapy?
I do to some degree, but I feel like even after 15 years, I have a hard time predicting or being able to determine who's going to get those side effects. BCG has a lot of odd things that happen. I don't know how much should be attributed to it and how much shouldn't. You end up trying to figure that out with the patient as you're sort of moving through treatment. Most patients tolerate it fairly well, but there are those that definitely get some impactful side effects. We talk about, is there options to switch if they do experience those? Gemcitabine docetaxel, most do well, but it's a long treatment. Not everyone's bladders can always handle one for, sequential medication, a catheter for at least a part of that time, or double catheterization, nor like the 3.5 hours needed to sort of accomplish that. So I think that sometimes plays into it too for BCG. Single catheterization, you can instill it. Most can go home, hold it on their own for like the 2 hours, and then kind of go about the day. With gemcitabine docetaxel, you can get close to it, to some degree, but it is a little more of time and input for those patients. However, the side effect profile is different, right? And so it can sometimes be more tolerable. You can give pre-medications with sodium bicarbonate to help, but I think it's about talking to the patient a little bit on how you'll help them manage side effects and trying to choose therapy really based on some of these other factors. So right now, it's a really long way of saying that I don't think I'm using side effect profile as much to help patients choose at this point in time. And I use some of the other things a little more, but I do acknowledge that we likely will need to help with side effects as they come. And we have a teaching sheet and some other things that kind of help patients frame what they're experiencing into terminology that we can then hopefully address and help with.
Absolutely. I think there's a lot of biomarkers coming out there that might be able to predict efficacy, but the next phase, if we could predict tolerability and side effects, that would really be the home run to help select patients' best treatment options. So some patients, they really want to be involved in the decision-making process and they embrace that shared decision-making concept. I've had a lot of patients come and see me that say, look, you're the expert on this. Just tell me what to do. Or what would you do yourself? How do you navigate that type of a situation?
Yeah, it's just going back to reading the room. Hopefully you've developed a rapport with that patient. This isn't the first time you're talking to them about their bladder cancer diagnosis. I practice in a very rural, underserved area with poor health literacy for the most part. And a lot of patients just say, if I was your dad or I was your mom, what would you do? And I give every patient the benefit of the doubt, assuming that they want me to go in depth with staging and grading and risk stratified adjuvant therapies and tolerability and efficacy. But some of them just kind of, eyes roll in the back of their head and kind of glaze over, and they just kind of say, I know, doc, but what would you do? And that you just got to kind of meet the patient where they're at and help them still make an informed decision. It's not a unilateral top-down approach. Even patients with poor health literacy can make an informed decision. You just have to tailor that education to exactly what they need.
Sima, you mentioned the CISTO trial, which I think has caught a lot of us by surprise with its findings and clearly has some implications for patient counseling. Can you give us a quick summary of what the trial showed and how that's impacted your practice?
Yeah, I think when you look at it from a patient counseling perspective, it is a great study to bring in when, in the setting of BCG unresponsive bladder cancer as you're moving through all of the increasingly complex options, right? And you talk about radical cystectomy still being a very valuable tool. A lot of patients will, of course, say, well, what will my life look like after that, right? And so then you can describe a little bit about what it's like to live with a urinary diversion and the impacts of cystectomy from also like a sexual function perspective. And then that's when I bring in the CISTO study. I'm like, so we don't have data where folks have been randomized to getting cystectomy versus an intravesical therapy, right? I said, we actually tried that. And most patients were like, well, did that work? And I was like, no, it didn't. It actually didn't work. We were unable to accomplish that. And so a really interesting study was done, and I try to explain what a pragmatic clinical trial is, and I'm not sure I understand myself completely, but I talked to them about, the purpose of this trial was actually looking at health-related quality of life as the main outcome measure. And that's in these different domains of global health, physical health, mental health, and sexual health, right? And urinary health, as well as I think there was some capturing of some bowel symptoms in that as well. So it's sort of looking at all these different things that cystectomy can impact, but also these different side effects you can get from more intravesical therapy. And then I sort of explain that when you kind of look at the two groups, those that went forward with bladder preservation compared to those that went forward with radical cystectomy, in the end, from a patient's voice and also caregiver input, that quality of life was actually fairly good despite having a big surgery. And then I talk to patients, I think that really sort of shows that bladder preservation is definitely possible from an oncologic perspective. But it does come with maybe these side effects that either we need to pay attention to and treat better, or that can slowly impact quality of life over time. I think that's the hard part, is trying to look in the future in like comparing this gradual process that could happen versus this radical change, like all of a sudden now having a urinary diversion, right? And I think that's a really hard thing to grasp. But what I think that the data does is that it gives comfort to patients that, okay, other people made it through. And I usually say patients are resilient, right? So I don't think there's a right or a wrong option. We just have to find the best option for you. And then this is also a really good part where you bring in, okay, so what are sort of your goals? What are things you're looking forward to in the next few years? What are things that are important to you? What do you want to do? Because that's where you really sometimes get some of that understanding on, is someone really informed? So if they're like, oh, I'm really worried I'm never going to be able to swim again. Well, that's not true. You can indeed swim with a urinary diversion, right? And I'm lucky I have a lot of my former patients who have chosen both paths and are willing to talk to current patients about how they kind of went through that process. And then there's also our big patient advocacy organizations, Beacon also has a peer support and outreach program that can be really helpful. So I do think it's like an iterative, pretty complex conversation. I do think that data I bring that in right when patients ask that question, and it sort of helps you sort of sort through, is this going to be the right thing for the patient? But it also lets you know what they're worrying about, because it's not always what you expect. I think that's the hard part, is that there's a lot of things going through someone else's mind. You can't really walk in someone else's shoes, but you can acknowledge their journey and then what their anxiety, worries, kind of thoughts are, and then try to figure out if you can help them make a decision from there.
No, really good points. I think when we just look at the history of NMIBC and how we use radical cystectomy, historically, there was kind of a low threshold to consider it, especially from an efficacy standpoint, because we didn't have a lot of good options. Then we kind of entered this era where we had a lot of exciting new things to try, and we're trying to save bladders for as long as possible, because that's what we thought the patients wanted. And CISTO was really eye-opening because it showed, or kind of proved, that it's not all about saving the bladder as long as possible for every single patient. The other take-home point for me was, it just shows how important these research studies are to really highlight these points and show what's really happening. Great discussion. Pat, any final take-home points that you want to make?
Yeah, I think defining intravesical therapy toxicity and some of these morbidities from repeated resections is critical, especially finding objective ways to measure these for things like clinical trials. I know we're working on some of that through the International Bladder Cancer Group. We have our annual meeting next week, and we're working on exactly that, using patient advocates, clinicians to kind of develop toxicity scales to objectively quantify some of this bladder-related toxicity, not just from surgery and intravesical therapy, but also radiation and systemic therapies. So stay tuned. Really excited about that initiative.
I think this is a really exciting time in bladder cancer care, right? I think that we have such a large armamentarium of resources within which to treat our patients. And so I'm really excited about the future and the work that's being done in terms of taking better care of our patients. It's been really fun and a privilege to be a part of.
Nice. Well said. It's been great having you guys. This was a lot of fun.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.